Hi, I am Dr. Raina Young, a family physician from Minnesota, and I am on the board, the Minnesota Board of Physicians for National Health Plan. I am helping record the webinar about COVID-19 endangering healthcare workers for Physicians for National Health Plan. These slides were prepared by Dr. Ed Weisbart, so thank you very much. Everyone bear with me. It's my first Zoom recording, but these are strange times that we're living in right now. So I was going to do this with the Star Wars Rebel base behind me, if you get my reference, you know, against the Empire. However, I didn't really have a good solid background for that to work, but the intention was there. So I like to start it with a quote from our former Senator, Dr. Paul Wellstone, who had said, "We all do better when we all do better," which I believe wholeheartedly. All right. On the front lines of fighting COVID-19, it's not only pushing the limits of our healthcare system, it's also attacking the very people who are that system. Today, we're going to discuss the impact of the pandemic on healthcare workers, what this means for patients in need of healthcare, and how a single payer improved Medicare for all has some built-in strategies that would help in situations like the one that we find ourselves in today. So far, 729 healthcare workers have died of COVID-19 as of July 1st of 2020. And when we say this, we're talking about the entire healthcare community, beyond doctors, nurses, respiratory therapists, paramedics, the ones that maybe you think about more or more in the front of your mind. It's also the people that help keep the hospitals and clinics running, x-ray techs, lab technicians, and unsung heroes such as transport staff, janitorial staff, house cleaning, and people who help with the cafeteria. Here's a list of just some of the many different healthcare workers that we're talking about, many of whom are in a rather thankless part of staffing, unfortunately. They are lost on the front line after helping patients during the pandemic. More than 80% of nurses estimated have not even been tested, and that was by late May of 2020. And of course, many other healthcare workers have not been tested either. Luckily, because many of us are asymptomatic, but that doesn't mean that we're not coming into contact with patients quite regularly and are just hoping that we don't have an asymptomatic COVID-19 infection. Interestingly, Trump halted regulations that would have protected healthcare workers against coronavirus, influenza, tuberculosis, many other infectious diseases. From the resource that is down at the bottom of this slide, these are some citations from some excerpts from that, I should say. When he took office in 2017, his team stopped work on new federal regulations that would have forced the healthcare industry to prepare for an airborne infectious disease pandemic such as COVID-19. That decision is documented in federal records that were reviewed by NPR. If the rule had gone into effect, every hospital, nursing home, etc., would have had a plan to make sure that they had enough respirators, that they were prepared. And that was said by the head of the Occupational Safety and Health Administration, David Michaels. There's still no federal regulations, specific ones, protecting healthcare workers from deadly airborne pathogens. OSHA experts were confident that new airborne infectious disease regulations would help and make it safer. And that's because there are already rules that are similar to that for blood-borne pathogens, such as Ebola and hepatitis. But federal records reviewed by NPR show that OSHA went step by step through the process for 6 years. And by early 2016, the new infectious disease rule was ready. The Obama White House formally added it to a list of regulations scheduled to be implemented in 2017. But in the spring of 2017, the Trump team formally stripped OSHA's airborne infectious disease rule from the regulatory agenda. So far, they hadn't been able to find any indication from the new administration about why. Instead, it appeared to be part of a wider effort to cut regulations and bureaucratic oversight. But the infectious disease standard would have required the healthcare industry to do far more. It would have forced facilities to stockpile personal PPE to handle surges, for example. They also found that the lack of fixed regulations allowed the Trump administration to relax worker safety guidelines. Federal agencies did so repeatedly this spring, as we know, that way hospitals could actually say that they were meeting federal guidelines while requiring doctors and nurses to reuse masks and other PPE, even after exposure to sick patients. Healthcare workers were already at a high risk of severe illness or death for many reasons, actually. 26.6% are at higher risk because of their age or chronic health conditions. 28.6% of all patient contact personnel do not have paid sick leave in our country. 600,000 live in poverty, impairing social distancing outside of work. If you think about it, when people are in the poverty level, it tends to indicate more reliance on public transport, denser housing with less potential for social distancing, and frequently without the paid sick leave time. Also, 11.4% of workers with diabetes, 28.8% of workers with chronic lung disease, they're uninsured despite the fact that they actually even work in healthcare. It's particularly dangerous for workers in home care or nursing homes. This is looking at the percentage without health insurance here in the United States. In total, it's 9.1%. However, with nursing home workers, it's 11.5% who are uninsured, and home care workers, it's 14.9%. 58% of workers in home care and nursing homes earn less than $30,000 a year. 26% of them are Black Americans. 82% are women, and 7% are age 65 and older. Americans in general are using less healthcare, including for life-threatening issues during the COVID-19 pandemic. This is a very interesting chart about how visits have decreased in emergency departments before and then during COVID-19. With uncontrolled blood sugars, visits have decreased by 10%. People with stroke symptoms, they've decreased by 20%. And heart attack symptoms, the visits have decreased by 23%. Now, we know that there's no biologic reason why there are 23% fewer heart attacks during the COVID-19 pandemic. So this would probably indicate that a significant number of people with these symptoms are staying home and taking their chances. We'll probably have more data in a few months about non-COVID mortality rates. Some of the avoidance of the emergency rooms is because of fear of contracting COVID, but another chunk is probably due to increased numbers without insurance. And then there are more financial barriers and fear of the cost of care for a very good reason, as we all know. Family physician offices have been closing during the pandemic, and a lot of my patients have the misunderstanding that we've been extremely busy during the pandemic, but actually the first couple months of it, primary care offices were very quiet because we wanted to keep people out of the office unless they needed to be seen, obviously. And so it was actually extremely quiet. And when you're based on production, as much of our system is, that does not bode well financially. Family physicians and office-based practices, there were 138,707 at the end of March of 2020. Jobs in family physician offices, including the physicians, were, 1.8 million or so. By the end of June of 2020, it was down 58,000 for family physicians and office-based practices. The jobs in our offices down 784,133. And that is a very large chunk. Many offices have been closing, staff have been getting furloughed or laid off. And here we look at the counties in the United States that have more than 3,500 people per family physician. The red counties are shortage areas where they have more than 3,500 people per family medicine provider. I believe that this one might be March. This went up to 1,037 in April, 1,400 counties by May, 1,800 by June. A dramatic deterioration in just a few months. Now more than half of the United States counties have more than 3,500 people per family physician. Healthcare workers have been fired and furloughed much more than the insurance industry workers. In ambulatory care, the change in workforce has been down 14.9%. This was in March and April. Hospitals, it was down 2.6%. Insurance companies, down 0.2%. Of course, they've insulated themselves as usual. And it does make you wonder what is wrong with a healthcare system that protects the insurers better than it does those who are actually providing care. 266 United States hospitals announced furloughs in April and May of 2020. These are some examples of some organizations. Of course, in my own state of Minnesota, Mayo Clinic, 30,000 furloughs or cut hours. Interestingly, in Spain, the government announced it was hiring 50,000 additional healthcare workers, because that would seem to make sense, wouldn't it? That during a pandemic, we would actually need more healthcare workers and not less. Why are employees being furloughed during a pandemic? It's because of how our system is set up. People are avoiding the emergency rooms for a variety of reasons, like we already covered. But another large part is that hospitals and healthcare systems are deeply dependent on the lucrative procedures. And elective surgeries were put on hold. And that was created a profound impact on hospital bottom lines, contributing to furloughs. This pandemic has definitely revealed what a bad idea our system is, that our economics are driven by the pursuit of these lucrative procedures, ones that are reimbursed much better or are private pay. Here's an example of Steward Healthcare and their urgent care centers, community hospitals, nursing facilities, all the beds, but the statement of that it created a seismic financial shock. Because elective surgeries are the cornerstone of their hospital system's operating model, which is true for many. I know my healthcare system is closing 8 clinics permanently, as well as having to end certain services, like home care and some various other things. Medicare for All would help protect hospitals by creating global operating budgets. Right now, hospital financing today, per patient payments make hospitals dependent on the most profitable services, as we already talked about. And surpluses tend to get invested back into those more profitable services. If we had a Medicare for All system, there would be global budgets. For each hospital, it would help align resources with the health needs of the community. So instead of each group doing it for their own group, we would be able to look at it as a whole. It would create a budget of reserve funds for pandemics and other natural disasters apart from regular operations. We really have a series of Band-Aid solutions. And if we had had a single payer system in place already, that would have been very helpful for this pandemic. It's also not widely recognized, but there's actually specific language in both the House and Senate single payer bills that would establish a budget for pandemics. Medicare would make rapid innovation easier. Pay is for telehealth. You'd be able to see and hear your doctor using your phone's camera at home. Medical practices can remain open despite patients staying at home. Medicare actually led the way on innovation, and the VA as well. Many corporate insurers have followed Medicare's lead. So many of us now have that ability as well, but it took each individual organization to figure out how they were going to implement telehealth. Medicare for All would do this better. We would have fast and universal implementation of important public health strategies and would help get corporations out of the way of healthcare. We all need healthcare. Everyone would have coverage regardless of age, income, or job, including healthcare workers. Purchasing and logistical power to provide adequate PPE could be directed to hotspots. We wouldn't have furloughs because there would be global hospital budgets, meaning equipment and staff can be redirected towards pandemic care. Single payer is not a panacea, but it does put in place systems and alignment that we need to protect our health, our healthcare system, and our healthcare providers. For more information on how an improved Medicare for All system would help with this, please visit physiciansfornationalhealthplan.org. Can also check out our kitchen table series. If you've got additional questions, there's some resources on here. And these are some of the other kitchen table campaign topics to help spread the word. I believe that covers it. Thank you very much. I hope we can find that this pandemic is at least helping put a, what would I say, a different lens on our need for a single payer system and an improved Medicare for all for our country. Thank you very much. Stay safe out there.